All right. Preceptors, make sure you get a eval sheet. I think there's some sitting in between the front and back rows, or Brittany can pass those out. All right. So we'll go ahead and get started. I'm happy to introduce you all to our PGY2 infectious disease pharmacy resident, Mitchell Thielen, and he's going to talk to us about updates to the CLSI breakpoints. What's the point?
All right, so I have no disclosures other than the fact that I do have a cold right now. So I'm sorry, I sound a little raspy. It's not COVID. If I have to step aside for a second, I'm just clearing my throat. All right, so objectives for today's presentation include to define minimum inhibitory concentration values and breakpoints, to evaluate the process of updating breakpoints, to break down the translation of breakpoints to clinical practice, and to discuss recent key changes in breakpoints while still correlating them to clinical practice. So the lowest concentration of an antimicrobial agent that can inhibit the visible growth of the microorganism being tested is the minimum inhibitory concentration. The lowest concentration that can kill 99.9% of the inoculum is considered to be the minimum bactericidal concentration. So this example on the right-hand side would have an MIC of 2 or an MBC of 4. Now, targeting MBC is not routinely done, really for two main reasons. The first being that the MBC test requires subculturing of the last clear MIC tube in order to ensure there's no bacterial growth. And as you can imagine, this would create a lot of additional steps to each culture and would cause a large amount of strain on the microlab as well. And then additionally, studies have shown MIC testing to be sufficient enough to treat infections. And this makes sense because, as we know, infections are treated by three things, first being antibiotic, second being the immune system, and then the third being source control. So anytime we have an infected patient, we do need to take all three of those things into consideration. So a breakpoint is the MIC value used to categorize an organism as susceptible, dose-dependent, intermediate, or resistant. And susceptible is defined by a breakpoint that implies isolates with an MIC at or below are inhibited by the usually achievable concentrations of an antimicrobial agent. And susceptible dose-dependent is defined by a breakpoint that implies isolates are inhibited only in the setting of higher drug exposure than what is suggested for a susceptible breakpoint. And this is obtained through higher doses, more frequent doses, extended infusions, or all of the above. So the intermediate breakpoint indicates we will likely attain appropriate blood and tissue levels, but we'll have a lower chance at seeing a response. The value itself includes a buffer zone for variability between different testing methods as well as different practice sites. And additionally, we can see automated testing as sort of a trade-off. We sacrifice always obtaining an exact MIC value for the major boost of convenience and efficiency, really. For this reason, an MIC may fluctuate plus or minus 1-2-fold dilution. So for example, say we have a patient with E. coli bacteremia. They're at high risk for persistent disease, so we're going to follow surveillance blood cultures, starting with an MIC of 0.5 or below. And then on day 2, it bumps up to 1. So at this point, do we panic? Is this organism getting rapidly resistant to levofloxacin? Do we need to switch therapy? Often no, there's no need to panic. This is usually just the 1-2-fold dilution buffer zone, and often the next culture will reflect the initial value. So to this point, antibiotics are likely still effective even at intermediate breakpoints, either due to this buffer or due to easily saturated sites of infection, which we'll sort of get into here soon. So where do breakpoints even come from? UCAST is the committee that addresses breakpoint criteria in Europe. So all European hospitals and healthcare systems follow UCAST breakpoints. USCAST is UCAST affiliated and was formed to not only provide a US voice to the UCAST process, but to also provide breakpoint decision support to the US FDA and other interested parties like CLSI. Now, this is done to promote harmonization between all these groups. It's very important to have globally agreed upon breakpoints, as this will help excel research and improve outcomes. Sort of stating the obvious here, but it's very difficult to compare studies side by side when they have different categorizations of organism susceptibility. So per US laboratory accrediting organizations, either CLSI or FDA breakpoints can be used, but the question becomes which ones should be used. FDA breakpoints are also referred to as STIC, which stands for Susceptibility Test Interpretive Criteria. And I do want to talk about the Cures Act that was signed into law in 2016. This was done to help accelerate medical product development and bring new innovations to light faster and more efficiently. So as a result, now companies are able to provide data summaries like observational studies, insurance claims data, patient input, and just generally anecdotal data rather than full clinical trials in order to get things approved more quickly. As a result, the FDA relies only on in vitro data provided by sponsors or third parties to update or establish their breakpoints. Also, the only breakpoints manufacturers can use when creating new testing methods for microlabs are those provided by the FDA. Now, why might that be a problem? FDA breakpoints and CLSI breakpoints sometimes don't align. So when CLSI makes these breakpoint updates, microlabs might not be able to adapt to these changes. So unlike FDA breakpoints, CLSI breakpoints are created based on much more in-depth data, including PK/PD studies and clinical trials. So again, sort of self-explanatory, but this is very important to study both ends of the spectrum here. You know, how the organism is susceptible in a petri dish and how it's susceptible in a patient. And we can see differences over years and years leading to decreased clinical efficacy, safety. So it is important to keep all these things in mind. Additionally, CLSI is very close with USCAST and then in turn UCAST as well. So collaboration is key here, as previously mentioned. Here I've got really the bread and butter of CLSI documents. This is the M100. It contains breakpoints for all of the most common organisms you will come across in clinical practice. And it's found on their website, but I did want to mention this Excel spreadsheet that they also offer on their website. I actually put this in the X drive under the name you see up top here. And I really just want to point out how to use it real quickly. On the left-hand column, if you select the sort of logo in the red box, you can actually unselect all the drugs and just choose the one you're looking for. And alternatively, if you're looking for an organism, that's what the next column over is for. You can just select the organism and find what you need much quicker than sifting through the website, to be completely honest. And then another cool part about this is that it shows FDA breakpoints as well, and it shows which ones match up and which ones don't match up. All right, oops. So since breakpoints are largely based on clinically rich in vitro data and in vivo data, they are considered robust predictors of clinical outcome, but there are many more things to keep in mind. For the sake of time, we're just going to focus on the site of infection, which leads us to the question of, are we going to achieve sufficient drug concentrations at our site of infection? So working through a few examples here, if the infection is in the GU tract, we'd like for our drug to be renally excreted. If it's in the bloodstream, we'd like a low volume of distribution. If it's a skin and soft tissue infection, we'd like a large volume of distribution. If it's in the central nervous system, we start to get pretty picky about what we want. But Big points here really are just renal excretion and volume of distribution that we want to think about. Starting with renal excretion, to help emphasize the importance of this, I want to sort of discuss the study that was published by Yetzko and colleagues in 2023. They compared cephalexin 500 milligrams twice a day to 4 times a day for the treatment of uncomplicated urinary tract infections. So all tertiary resources and package inserts recommend 4 times a day dosing. So with that being said, we can sort of expect the twice a day group to do worse. But that wasn't the case. There was no difference in treatment failure or 30-day recurrence between the two groups. Now, how is this possible and how does it make sense? Does this mean we're dosing everything wrong, or what's really the explanation here? It can really be explained by this awesome chart. One of my favorite charts was published by Gilbert and colleagues in 2006. And it shows that many antibiotics actually achieve more than 100 times higher urine concentrations than serum concentrations. So current dosing for UTIs might be a bit exaggerated because they're based on serum concentrations. And when looking at cephalexin in particular, it makes total sense as to why the twice a day cohort experienced similar outcomes to the 4 times a day cohort. Additionally, for these same reasons, an agent may still work even for organisms intermediate or even resistant to the agent. If we see a clinical response in the patient and then get the susceptibility report and it shows intermediate, there may not be a reason to change if it's an easily saturable target. So moving on to volume of distribution, extracellular fluid has a volume of roughly 0.3 liters per kilogram. So drugs with volumes of distribution below this value will stay in the extracellular fluid. So these agents are ideal for bacteremia. We've got daptomycin, sulfamethoxazole, penicillins, cephalosporins, and carbapenems. Intracellular fluid has a volume of roughly 0.7 to 1.0 liter per kilogram. Thus, drugs with volumes of distribution within or around this range will evenly distribute throughout the body. With that being said, these drugs can be used for bacteremia or tissue infections. We've got linezolid, metronidazole, vancomycin, doxycycline, and the various fluoroquinolones. So drugs with a volume of distribution much larger than 1 liter per kilogram tend to be lipophilic, and they will rapidly leave the blood and concentrate within tissues. That being said, they're ideal for tissue infections and not bacteremia. We have eravacycline, tigecycline, azithromycin, and trimethoprim. This trimethoprim, does that mean Bactrim is bad? Not necessarily. We see how both components work very well together, and this is why Bactrim is used so often across the board. And as ID, we are just big fans of it. That's why we recommend it all the time. So here we've got a timeline of the recent updates that we will discuss, starting with fluoroquinolones, pip/tazo, and then aminoglycosides, and an additional update for levofloxacin. Starting with 2018, the fluoroquinolone breakpoints here, the only thing I really want to point out for now is the susceptible breakpoint of ciprofloxacin being 1 or below. And that is because when we think about why these breakpoints were updated, a big factor is when they looked at this susceptibility across a little over 62,000 isolates, it actually declined from 95% to 81% between 1998 and 2013. So this was a big red flag, and sort of prompted the discussion of what are we going to do about this. And additionally, there were a lot of advancements in PK/PD modeling. We've got Monte Carlo simulations, which can be used to model probability of target attainment values for a variety of MIC values and pathogens. And also USCAST. provided a 250-page document, sort of breaking down all the PK/PD studies, correlating them to clinical studies, and sort of rationalizing what we can do to update these breakpoints. So when cross-referencing PK/PD studies and human studies, a non-clinical AUC to MIC target of 67.4 for Enterobacterales and 47.3 for Pseudomonas, each translated to a clinical free drug AUC to MIC target of 72. With that being said, 72 is the magic number that we will be looking for in a lot of the following slides, so just keep that one in mind. So here we have percent probabilities of PK/PD target attainment by MIC. And again, we're focusing on when the AUC to MIC drops below 72, which is indicated by the red text in the tables. So here we have values from the last slide laid over MIC distributions from Century Antimicrobial Surveillance Program from 1998 to 2013. On the y-axis, we have the percentage of time we achieve PK/PD target attainment, shown by the red and blue lines, whereas the frequency of isolates having the MIC value displayed on the x-axis is depicted by the size of each bar in the bar graph. So we see that drug concentration stays above AUC to MIC of 72 up until the point signaled here by the arrow, so at an MIC of 0.25. Now we're starting off with kind of a wonky example because normally we would make that the intermediate breakpoint since it falls below our ideal value. But that was actually made the susceptible breakpoint as 0.25 or below. And this was done for a couple of reasons. The first being, this is also the UCAST breakpoints. This is also FDA breakpoints, so it does promote harmonization. Additionally, most infections being treated with fluoroquinolones are UTIs. So we now know that urine concentrations are much higher than serum concentrations, and we're likely adequately treating the infection. Then also a lot of organizations, including Erlanger, susceptibility panels don't go down to 0.125. So even if they did change the breakpoint to 0.125, we wouldn't ever be able to see it or know if our organism is truly resistant or truly susceptible, rather. So for Pseudomonas, we have the same style of data laid out here. And when looking at the full picture, we can see we sort of dip below 72 at an MIC of 0.5. But what I do want to point out about this slide is this is depictive of 750 milligrams by mouth every 12 hours. But given the bioavailability differences between PO and IV, when we translate that to IV, this is 600 milligrams IV every 12 hours. So that is reflective of 1,200 milligrams a day. So we take that same amount and we move to this slide where we have 400 milligrams every 8 hours, which is still 1,200 milligrams a day, but we now are pretty strong through an MIC of 0.5, and we can treat up to an MIC of 1. So for that reason, the intermediate value was made of 1, and it's susceptible at 0.5 or below. And also, they clearly recommend that you use the Q8-hour regimen as opposed to the Q12-hour. Moving on to levofloxacin, it's very, very straightforward compared to ciprofloxacin. So we can see we get into trouble at an MIC value of 1. And that is also depictive of the graph here, looking at the full picture. And since it is 100% bioavailable, this is the breakpoints listed here are for IV, PO, either or. You will use the same breakpoints. When looking at Pseudomonas, we see an MIC of 2 is when we really severely drop off, which is additionally shown by the graph here. And so really to keep things simple, that's what we made that's what CLSI made the intermediate value and thus susceptible value of 1 or below. All right, animations are a little wonky. Okay, so here's our first assessment question. 63-year-old female with a history of pan-susceptible Pseudomonas UTIs presents with dysuria and fevers for 4 days. Urinalysis was performed, which showed leukocyte esterase and white blood cells greater than 182. So it was reflex to urine culture and empiric levofloxacin was started. The culture finalizes 2 days later, but before we take a look at it, the patient is stating that the patient is clinically improving, and she's also stating that she feels a lot better. With that being said, here's our susceptibility report. And that brings up our question of what are we now going to do with that information? So the right answer here would be to continue levofloxacin. We know we're achieving adequate concentrations in the urine. She's getting better. There's really no reason to flip everything upside down and complicate things. It wouldn't be the first option because she does have dysuria. She is symptomatic. It wouldn't be the third option. It could be the third option, but that would be a little unreasonable because it would be keeping her in the hospital. It would increase costs, increase complications. We don't want either of those. Then lastly, while ertapenem is often used as outpatient infusions, it doesn't cover Pseudomonas, so that would be a wrong choice off the bat. All right, moving on to pip/tazo. These are the breakpoints, previous breakpoints from 2021, really focusing on a susceptible value of 16, intermediate value of 32 to 64, 64 being if if the infection is localized to the urinary tract. So why were these updated? They were first established in 1992. Since then, there's been a lot of advancements in PK/PD modeling, as already discussed. But also, we've got a better understanding of beta-lactamases now. And we essentially separate them into 2 categories. The first being those that are easily inhibited by tazobactam, like TEM, SHIV, or CTXM. But unfortunately, we also have those that are poorly inhibited by tazobactam, like AMP-C, OXA1, OXA30. And additionally, these beta-lactamases can co-harbor. So even though we might see a positive BCID for CTXM, that doesn't always exclude OXA1, for example, from also being present. So this is a large reason as to why carbapenems are considered to be first-line therapy for most ESBL infections. So now we'll get into the Merino trial. I'm sure a good bit of you have read this trial or seen this trial. But for those who haven't, this trial compared pip/tazo 4.5 grams every 6 hours over 30 minutes versus meropenem 1 gram every 8 hours over 30 minutes. So both standard infusions for the treatment of ceftriaxone-resistant ESBL, E. coli, or Klebsiella pneumonia bloodstream infections. I did want to point out for the pip/tazo group, half of them were of the urinary source, and then the runner-up was intra-abdominal source. So when looking at outcomes of 30-day mortality, this was seen in 12.3% of the pip/tazo group, 3.7% of the meropenem group, which was a statistically significant difference. But when we start to break this down, the pip/tazo group had 23 deaths. 6 of these deaths, the patients had metastatic cancer. 5 of them had advanced cancer. In the meropenem group, even though this cohort had more patients, technically, they only had 7 deaths, 2 with metastatic cancer and 1 with advanced cancer. So we immediately start to question whether or not the pip/tazo group was predisposed to worse outcomes because of these patients with poor prognoses. But to the theme of this presentation, we want to know what the MICs were of these isolates and how they correlated to mortality. So there was a post-hoc analysis published in 2021 by Henderson and colleagues that looked at these things. And what they found was there was a considerable amount of patients at an MIC of 16 or even above in this cohort. And when we compare them sort of side to side with the meropenem cohort, we can see that we're really much more flirting with disaster in the pip/tazo group as opposed to meropenem group. So it kind of makes more sense why there were slightly worse outcomes in the pip/tazo group. And then when we directly compare percent mortality to the pip/tazo MICs, we saw when it was an MIC of 16 or below, we had 9% 30-day mortality, but an MIC above 16 was indicative of 50% 30-day mortality. And that is very much a problem, as our previous breakpoints were, the intermediate value was 32 to 64. So all of those patients were surviving on a flip of a coin, essentially. When we look at pharmacokinetic data from 105 hospitalized patients obtained from 2 studies, so this was kind of combined by Patel and colleagues and published in 2010. They first looked at a dose of 4.5 grams every 6 hours over 30 minutes, so standard infusion. And they looked at when the MIC started to drop below 72, which, as we can see here, it happened at an MIC of 8. But when they looked at a lower dose over a longer interval, but through extended infusion, they noticed that these patients were obtaining concentrations that are pretty strong throughout an MIC of 8 up to an MIC of 16. So when we combine these 2 pictures here, we get, if we use a higher dose more frequently over a longer period of time, we can assume that we are safe at an MIC of 16. And so for that reason, this influenced the updated breakpoints to reflect a new susceptible dose-dependent breakpoint of 16. Now, for this MIC value, we need to use 4.5 grams every 6 hours over 3 hours, or 4.5 grams every 8 hours over 4 hours. Otherwise, if our MIC is 8 or below, we can use the standard infusion dosing. Moving on to aminoglycosides. These are the previous breakpoints here. These breakpoints were introduced in 1979 and were never touched again. So needless to say, there's a lot of data at hand to help update these breakpoints, and it very much needed to happen. Additionally, the new CLSI aminoglycoside breakpoints are based on bacterial stasis. So meaning that these agents are suitable for patients with low bacterial burden, good source control, minimal comorbidities, which often tend to be UTIs. And this kind of makes sense, as we have seen higher mortality when these agents were used alone in bloodstream infections in a few studies. So it sort of makes sense that they chose to target stasis instead of bactericidal action. And additionally, we now know that nephrotoxicity can be mitigated through the use of off-label, high-dose, extended interval dosing. This was a study published by Ryback and colleagues in 1999, looked at mostly gentamicin and tobramycin use. And we can see here, this first image shows Q12 dosing and the correlation between AUC and AKI, as well as when it was combined with vancomycin. But when we switch it to Q24-hour dosing, we can very clearly see how much more tolerable this is while without sacrificing treatment failure. So I think this is just a good visual depiction of how much safer exactly it is to do Q24 dosing. So for the next few slides, it's going to be kind of a lot of information, but I wanted to have this slide here as sort of a table of contents to explain what I'm going to show you all. I've got all of my sources listed here on the bottom. And first, we'll talk about PK/PD targets based on neutropenic murine infection models, percent probabilities of PK/PD target attainment overlaid over MIC distributions. These will be similar graphs to what we saw with the fluoroquinolone section at the beginning, but the data is from 2017 to 2021. And then lastly, we'll talk about CLSI breakpoint updates. Starting with gentamicin for Enterobacterales, as we can see up top here, we are strong through an MIC of 2 and fall into trouble in an MIC of 4, which we can see in the graph. So that led to an updated breakpoint, intermediate breakpoint of 4, which makes sense. But now CLSI strongly recommends the extended interval dosing of 7 milligrams per kilogram every 24 hours. When looking at Pseudomonas, we can see we're pretty strong at an MIC of 1, but at 2, we just completely fall off. And this was seen to be a big problem because, as we know through the sizes of the bars in this bar graph, most of the MIC values are 2 in all of the isolates obtained. So most of the time, this drug is ineffective towards Pseudomonas, to be put simply. For that reason, CLSI no longer recommends using gentamicin for pseudomonal infections, period. And they don't even offer breakpoints. They removed them, so it is completely erased. Unfortunately, our panels here do still report Pseudomonas, still do to report gentamicin for Pseudomonas. So I need you all to keep that in mind and educate your team if it ever comes up. Yeah, that's pretty much what we need to do. There are some ways we can hide the report or other things we can do, but for now, if it does come up in conversation, just let them know this should be completely ignored. When moving on to tobramycin for Enterobacterales, you can see we're strong up until an MIC of 2 and fall into trouble at an MIC of 4. So understandably, the intermediate breakpoint was set to be 4, susceptible being 2 or below. And similar to gentamicin, they recommend a 7 milligram per kilogram dose every 24 hours. For Pseudomonas, we can see that we're safe at an MIC of 1, but even stronger than gentamicin, we drop off completely at an MIC of 2, which is shown by this graph, but most of our isolates are not at 2. They are below 2. So we're okay here. And they did set it, the intermediate value is 2, same dosing. But the problem is our panels only report down to an MIC of 2. So we're never going to know if we have an isolate with an MIC of 1, 0.5, 0.25. All we're going to see is 2 or below. So this agent can be used to double cover Pseudomonas, like pneumonia, if we really feel strongly about that. But as monotherapy, it's going to be difficult to be confident in this agent. For amikacin, we've got traditional dosing, extended interval, and then 2 different doses of extended interval, 20 mg per kg and 30 mg per kg. As we can see, we're strong up until 4, drop off at 8, depending on which dosing strategy you use. There's a lot of lines here, but I just want to focus on this point. This is indicative of 20 mg per kg extended interval. So we can see we get into trouble at 8, which prompted the updated breakpoints, intermediate breakpoint of 8, susceptible breakpoint of 4 below. Now, they do recommend using 15 mg per kg every 24 hours and only for urine infections, which is slightly below our 20 mg per kg dose that was studied here. But that is because, referencing that table from the beginning of the presentation, we see almost 100 times higher concentrations of this drug in the urine than we do in the serum. For Pseudomonas, it's really the same pattern here. We fall into trouble at an MIC of 4. Unfortunately, a lot of our isolates are at an MIC of 4. And then even more confusingly, that the breakpoints weren't updated for Pseudomonas. Now, I kind of looked deeply into this. It's confusing as to why the Enterobacterales breakpoints were updated and Pseudomonas ones weren't. And the only explanation I could really come up with is because the FDA breakpoints are the same as this. So maybe they were more concerned about Pseudomonas panels being affected than Enterobacterialis panels. It's tough to tell, but it doesn't make much sense to change one and not the other. So it is just something I wanted to point out, and it is similar. The dosing strategy, at least, is similar to Enterobacterialis in the sense of 15 mg per kg every 24 hours. Now we can sort of feel safe about this because of, again, this fact at the bottom here, we do achieve much higher concentrations, but it is kind of confusing why one was updated and the other wasn't. So I know that was a lot of information. I wanted to provide this review slide of everything that was changed in case you need a quick reference. And a quick reminder that these agents should only be used alone for UTIs, and that is it. Moving on to levofloxacin with Stenotrophomonas. These breakpoints were established in the early 2000s, despite very little PK/PD data at this time. There are considerable differences between CLSI, UCAST, and the FDA in the sense that UCAST and the FDA don't have these breakpoints, so it's just CLSI driving this ship. So we have more data to assess at this point in time, and here are the former breakpoints here. Only thing I want to point out is the susceptible breakpoint of 2 or below. When looking at PK/PD data, 3 trials were reviewed in the committee meetings. Unfortunately, 2 of 3 used dosing that does not simulate clinically relevant levofloxacin dosing that we use in patients. But third time's a charm. Fertoni and colleagues in 2021 published this article where they did simulate the appropriate dose. And they noticed that PTAs for a 1 log 10 reduction were pretty sharply dropping off at an MIC of 2 and then getting kind of close at an MIC of 1. So this is why I wanted to emphasize the susceptible breakpoint of 2 or below. That might be a little dangerous. But when looking at clinical data, we first review a study published by Coe and colleagues in 2019. This was a meta-analysis, looked at 12 different studies, had a trim-sulfa group and levofloxacin group. These were mostly pneumonia or bacteremia cases in ICU and cancer patients. There were no MICs available, unfortunately, in these studies, but there were no significant differences in mortality between levofloxacin and trim-sulfa. Additionally, in 2019, Nis and colleagues published a retrospective study of 96 patients. Most were pneumonia patients. Compared trim-sulfa to levofloxacin, found no significant differences in clinical cures, microbiological cure at the end of treatment. The trim-sulfa group did trend towards benefit, but this did not reach significance. Then lastly, more recently, Starzinski and colleagues in 2022 published a pretty large study, looked at a large trim-sulfa group versus a large levofloxacin group, and they finally looked at MICs, but within the levofloxacin cohort, lower breakpoints like 2, 1, 0.5 were not associated with a lower mortality outcome. So just sort of digesting all of this information, a lot of these were retrospective studies with heterogeneous patients and outcomes. There was very limited correlation of outcomes to MIC values. And then one of the biggest points here is with Stenotrophomonas is the patient infected or are they colonized? Have they been wiped out from different agents and have now colonized Stenotrophomonas because of that? And thus it's just a poor prognostic indicator, or are they infected? It's hard to tell. There's really no strong way to do so. And I think that's reflective of the last study showing that those at an MIC of 2 were just as fine as those at an MIC of 0.5, even though our PK/PD studies showed 26% attainment values at an MIC of 2. So that begs me to think, were those patients infected or not? And that's really the $1 million question with these patients. Additionally, I wish I could get deeper into this topic, but there was a little bit of data that indicated quick emergence of levofloxacin resistance after being exposed to these agents. For this reason, in 2023, this year, IDSA published an antimicrobial resistance guidance document, and they now recommend 2 active agents for empiric therapy against Stenotrophomonas. And this was sort of, it felt exaggerated because if we have this suspicion for levofloxacin, then why are we translating that to all of the other agents, really? I think CLSI had a much more appropriate way to approach this in the sense that if you're going to use levofloxacin, since we have these sort of scary studies that exist, just don't use levofloxacin alone. So we can use that with another agent, or we can just use another agent as monotherapy like Bactrim or minocycline and just not be as worried about this problem. Okay. All right, so we have our final assessment question. Got a 41-year-old male, history of pneumonia due to multi-drug resistant Pseudomonas isolates. He's been admitted to the ICU in septic shock. Started on empiric pip/tazo and linezolid. However, the primary team wants to double cover for Pseudomonas. So which option would we not use? That would be gentamicin. That's just never on the table anymore. All right, so wrapping things up, we always want to consider the site of infection and volume of distribution of the drug we're using. We want to double check breakpoints when using fluoroquinolones for Enterobacterales or Pseudomonas. I have a green check mark here because our susceptibility panels are updated to reflect these breakpoint changes, so no worries there. Pip/tazo can be used for Enterobacterales up to an MIC of 16, but will then require 4.5 grams every 6 hours over 3 hours, or 4.5 grams every 8 hours over 4 hours. I've got the red warning sign here because our susceptibility panels do not reflect this information. They are still reflective of the old breakpoints. So be on the lookout for that. In addition to no more gentamicin being used for Pseudomonas, although it's still reported, tobramycin is essentially considered the aminoglycoside of choice now. And lastly, levofloxacin should never be used alone for Stenotrophomonas. I have a question mark after this statement because it is still a very highly debated statement, and this could be an entire different presentation based on this topic alone. So that's a medium statement, basically. That's all I have for y'all today. Thank you so much for coming. Here's a CE credit, and I'd be happy to answer any questions. Yes.
So I know CLSI, they have a lot of talk of urine cuts or urine isolates, and if the loans are used predominantly for urinary tract infections, same with the glycosides. And then you presented data on antibiotic concentrations in the urine. What do you think are some considerations with them changing all these breakpoints, but almost all of those agents concentrating highly in the urine?
Yeah, so the question, just repeat the question. It was, we know, now that we know a lot of agents concentrate very well in the urine, what do we think about the breakpoints being solely dedicated to serum concentrations and not really often mentioning urine concentrations, maybe adding additional breakpoints for urine concentrations? I think we should definitely have urine breakpoints for definitely the fluoroquinolones, especially if we're claiming they're mostly used for UTIs. But also, I think for all of the agents in the table that I showed, that we know most of them concentrate very well in the urine. We've known that since 2006 is when that was published. So I think it should be done. I understand it'd be difficult. It'd be a lot of data to put together if you want to prove it like clinically and whatnot. But I think in the perfect world, all drugs should have a urine breakpoint, definitely. Okay, if that's it, thank you all very much. I appreciate it.